Well, ladies and gentlemen, it is such a pleasure to be with you virtually or actually. I'm David Armstrong. I'm the founding president of the American Limb Preservation Society. I also just finished clinic now at the Keck School of Medicine of USC, where we have a team, a toe and flow team, not unlike you're going to hear from Kara Couch, Richard Bruno, and of course, Brian BDL Lepow today. I'm telling you, the big idea here is that you have to marry team and technology and with a little bit of tenacity. And I think that's what you're going to hear from all of us. And I just want to tell you how much of a pleasure it is to be with all of you today. And let me kick it over to my friend and now yours, Georgia Craybiel, founding CEO of ALPS.
Thank you, David. Yeah, welcome everybody. We're pleased to have you here, either afternoon, evening, depending on where you are. We have an excellent lineup tonight of KOLs and experts in the field of limb preservation. And, we're really glad to have this group with us this evening. If you are not currently a member of the American Limb Preservation Society and you would like to learn more, please, you can scan. Do we have a QR code? Or you could go to our website and use the code WOUND, and it will be $1 for this year. So if your membership is needing to be renewed or you want to be a member, please take advantage of this opportunity. I'm going to turn it over now to Kara Couch, who is Director of Wound Care Services at George Washington University.
Hi, good evening. So delighted to be with you. I hope everyone is winding down for the holiday season, or maybe in the middle of the holiday season, depending on what you celebrate. So tonight we're going to be talking about kind of soup to nuts. How do we do the thing that we do? And I think that I've 23 years in as a wound care nurse practitioner. We start out with complex wounds and different factors that affect wound healing. And, some of them are very obvious. If they have diabetes, if they are a smoker, if they have kidney disease, things like that. But I also just want to point out, connective tissue diseases, immunological disorders, chemotherapy, hepatic failure, and then nutritional deficiencies, because I don't think that we spend enough time talking about nutrition when it comes to its severe impact on delayed healing. Now, it's really important that we also recognize and differentiate the skin changes that we see in a timely manner. So key is understanding, what is it that we're actually treating? Do you know? I mean, the ulcer could be multifactorial and really get you off course if you're not really clear on what it is that you're really treating. So identifying the issue, figuring out the diagnosis, and then looking at the management, this really helps us to prevent the permanent damage that can come from prolonged tissue necrosis or infection, which leads to improved outcomes, which is why we do what we're doing here. Now, the different risk factors for limb loss are peripheral arterial disease, bony deformity, neuropathy. If the patient has had a prior ulceration, that's always a key sign for me that we may be off to the races quickly. If the patient has a limited eyesight, can they see their feet? Can they see their wounds to determine what's going on? Obesity plays a large role, particularly when it comes to venous outflow, because if you have a large pannus overhang, it really puts a lot of pressure on your iliac veins and leads to a lot of lower extremity edema, which is another high risk factor that these patients have. And think about your etiologies. These are the common things that we're treating. We're treating venous disease, we're treating arterial disease, obviously diabetic foot, and then pressure injury. And, there's a lot of very basic principles that I have up here for these things. Venous disease typically have a lot of exudate we have to manage, and they need to have compression therapy, plus minus some endovenous surgery. Arterial ulcers typically are dry. We want to keep them dry, and we need to get them blood flow. For diabetic foot, their big risk factor is in infection and working on glycemic control. And then with pressure injuries, offloading is key, as well as managing incontinence and nutrition. So from the venous standpoint, this is pretty typical venous ulcer on the medial calf, often in young patients. They can be very, very hard to heal. And again, the compression is the gold standard of care. However, did you know in the United States, we only compress 14% of all venous ulcers? Why is that? The data is unequivocal that we need to be compressing patients. So we as a society have a lot of work to do to get our patients up to the standard of care here. And if you look at the progression, the healing rates remain very, very low for these patients. So the venous leg ulcers affect about 1% of the population in the world and more than 3% of the older population. They're the most common type of lower extremity ulcers that we see. And crucially, between 57 to 78 of these ulcers recur within a year after healing. I saw a patient in my practice today who's been my patient for 17 years because he has end-stage venous disease complicated by a chronically colonized wound with Pseudomonas. So he's a delight to see. I know him very well, but I'm sad that I've been working on him for 17 years. When you think about the diabetic foot epidemiology, this is a global challenge, much like venous disease. And 25% of those with diabetes develop a diabetic foot ulcer. However, even though we revascularize some of these patients, 25% will still not heal, 50% will get infections, and 20% will get amputations. And we spend billions of dollars on this over the year. Now, this is pretty common for a diabetic foot ulcer that it's a result of neuropathy, the vascular disease, if there's tissue ischemia, and these patients have altered metabolism. But these are complex wounds. This is a terminal malignant disease. And these patients, whether we're treating them for pressure injury, for diabetic foot, for venous insufficiency, arterial insufficiency, they are at the end stage disease. We are looking at patients where by the time they get the external wound, that is telling us that they're at end stage disease, and it's all due to the underlying disease process that caused it. When you think about arterial epidemiology, there's similar risk factors for developing coronary artery disease and cerebral vascular disease, but PAD, peripheral arterial disease, has a unique risk for these patients, and it's increasing. If we only focus our sights on caring for those with diabetes and we ignore the arterial epidemic that is going on, we are missing 50% of the problem. It is a polyvascular problem, and so I'm trying to retrain my brain to move from peripheral vascular disease to polyvascular disease, meaning if my patient has carotid disease, if they have had coronary artery disease, if they've had a stroke, that is a polyvascular problem. So of course we're going to see it in their arteries. Now, when you take a history and physical, it's important to note what's in their past medical history. Do they have autoimmune disease? Do they have end-stage renal disease or any sort of renal insufficiency? Has there been any recent trauma or surgery? What are the associated signs of symptoms? How did this ulcer or this wound occur on this patient? What's their family and social history? If they say, oh yeah, my grandpa, he got his legs amputated and my dad did too. Or, my mother had swelling just like that. Those are clues and things that we need to think about. We want to look at their medications. Have they had any recent lab work? It's important to understand what their basic immune system is doing. I typically get a CBC, chemistries, as well as LFTs on my patients. And I always check a vitamin D level because if you have a vitamin D level of less than 30, they can't deposit collagen. So I need to know that so I can start supplementing them. And then I need to think about, what's the timing of their symptoms? Do they have palpable pulses? Do they have edema? Do they have sensory or motor function? When thinking about the drugs, obviously we know that the steroids, cause a lot of delays in healing. We want to know about anticoagulants, particularly if the patient's going to possibly need negative pressure wound therapy. Anti-neoplastic agents are good at healing cancer, but they can often cause a lot of different challenges that we have when it comes to wound healing. And then different vasoconstrictors like nicotine and cocaine are important to screen for. When you're thinking about the differential diagnoses, when you're in the field of horses, like, yes, you might hear hoofbeats, but don't forget about the basic things. And then you can layer in your differentials on top of that, because it can get very complicated when you move through this huge list that we have here. And this is a great paper that just shows that the ulcer could have a vascular etiology, could have a metabolic etiology, connective tissue disease, cutaneous microthrombotic, hematologic, neoplastic, as I mentioned, paniculitis, traumatic, iatrogenic, atypical, a martyral, which is a hypertensive ischemic leg ulcer, which is very underdiagnosed, but much more prevalent than we know, and then infection. So, woo, what a long list. As we mentioned, these wounds are very complicated and can be quite challenging to heal. So this is a quick example of a patient of mine that had a venous leg ulcer, and we had 8 months of refractory treatment. The patient had failed epidermal grafting, had failed hyaluronic therapy, had had different types of dermal matrices, but the patient needed a combination of multiple treatment methods to include a cellular or tissue product, negative pressure wound therapy, and compression bandaging, multilayer compression bandaging. You combine all of those together with consistent debridement and consistent wound management. And this is what sets you on the right journey for healing these quite complicated wounds. And with that, I'm turning it over to Dr. Lepow.
Thank you, Dr. Couch. Great job. And I'm going to talk a little bit today about the multidisciplinary approach into wound care. It's been well studied and well discussed about, the multidisciplinary team approach for management of these complex patients. And we're all here. We live it, we breathe it, we speak it. But how do we form it? How do we make it work? And who are the critical components of that? And what does the data tell us? Also, as a quick reminder, if you have any questions, just pop it into the chat and we'll get to those at the end of the lecture today. And so who should be on my team? And, I think that this list is probably endless for most, but I think they're the key core components, and then there's some of the ancillary services that I commonly think about. And so, don't hopefully I don't hurt any feelings by leaving anybody off this team, but there's so many partners that are involved, and somebody who works now kind of both in academic and private settings, the team is very much a critical part of the success of our practice. And so, I think being on that team, and there's various components and various levels of that team, depending on what your setting is and who actually is on that team. But for the most part, the toe and flow model really are two surgical specialties. It's podiatric surgery and vascular surgery all combined in one service. That was well discussed by and talked about in the literature by Dave Armstrong and Lee Rogers, Joseph Mills. And so, the toe and flow model really is sort of the basic core entities for a successful limb preservation model. And then from that, we look at a landmark paper that was written by a group of individuals who we all know quite well, talking about the essential components and structure to the amputation prevention team. If you haven't had a chance to read it, this is really a landmark, groundbreaking journal, combination journal with the American Podiatric Medical Association and the Society of Vascular Surgery back in 2010, really outlining and highlighting sort of the need and who all is part of that team. And so on the toe side, when we're looking at that team, outside of the core components, the other parts of that team would include the orthopedist, plastic surgeon, infectious disease is a really important part, wound care specialists, primary care physicians, APPs. And then on the flow side, you have your vascular surgeons, your interventionalists, and then your hyperbaricists, which, kind of sort of meet somewhere in the middle. And again, I think that, not to leave out orthotists, prosthetists, again, the APPs that help us to run our services and provide, the utmost care and sometimes, the top-notch care for these patients. This is definitely due for updating, but again, it's an endless really team. The team is large and it grows, and so this just kind of highlights the essential components of that team. And also, the Global Vascular Guidelines that it discussed in 2019, sort of how to create that center of excellence for amputation prevention. Who is that team, the setting, the components, the function? Really great articles to refer to, and just highlighting sort of the importance of why the multidisciplinary team works. We've seen it multiple centers across the world, how these multidisciplinary care teams work, both in private and academic settings. And we know that for the best success for these patients, it takes a village, it takes a team to help them get on their way towards diabetic foot remission. And we know that teams improve outcomes, right? Implementation of a multidisciplinary team not only reduces amputations by 34% in the Netherlands, but also worldwide. Amputations are reduced about 72% when you have that team approach in U.S. hospitals after implementing an amputation prevention team. And then studies from all over the world, including UK, Finland, Italy, India, and Australia, have all had similar conclusions. And, for those who are living and breathing limb preservation work or managing wound care, I'm sure you've heard about that team, and you know how important it is to have that team around you. Again, it don't matter what setting you're in, there's various components of this team that are available to each and every one of us. And I think that without that team approach, the success for our patients would certainly not be as great as it should be. And so what happens to the impact of establishing that care team? You have sort of all these different specialties, the outpatient services, medical and allied services, emergency medicine, sort of flowing into that limb preservation team. And then from that limb preservation team, it's the determination of kind of who does what and at what time. We've always kind of been taught that, if the patient has an infection, regardless of the flow, the toe team takes precedence, mitigates infection. Now, if the team and that patient comes into the ER and has a strictly vascular problem, an ischemic problem, and maybe a necrotic foot or a semi-stable foot, ideally the flow team would take precedence and be able to help revascularize that extremity, and then allow the team to come in from the toe side to continue care. So those are some key components there. And then a reduction in diabetes-related major amputation rates after implementation of the multidisciplinary model. Just another a great paper just highlighting the fact that once these teams are implemented, how significant the mortality rates drop, increase in, the interesting to note is that, while there's a decrease in major amputations, there typically is an increase in more minor amputations, toes, multiple toes, midfoot. But the idea is that we keep that limb, because we know that once somebody's lost that limb, their mortality rates are quite high, approaching 50% at 5 years, if not more. And so the idea is that by implementation of these programs, these teams, yes, more procedures are being done. However, it's an effort to save the foot, mitigate sort of a more proximal level amputation, and get these patients into diabetic foot remission. And so this was, widely discussed by Dr. David Armstrong, the four-step approach to a toe and flow model creation, kind of four basic entities. You have your kind of limb preservation programming. That's followed by what's called a hot foot line, where somebody comes into the ER. There's a automatic call or connection to that diabetic foot team or that foot salvage team. And then you have an active tissue clinic loss. So once the emergent problem has been managed, those patients then go into an active tissue loss clinic where they're screened regularly, undergoing extensive wound care modalities, hyperbarics, mist therapy, all those kinds of things that are used to kind of help treat and get these wounds in diabetic foot remission. And then we have the remission clinic, and those things are also really important, right? Because we all know that once somebody's had a diabetic foot ulcer, they're at a much higher chance of developing a secondary diabetic foot ulcer. And so I think that, or if they've already lost a limb, the statistics tell us that you're at a greater than 70% chance of losing another limb. So going into those remission clinics are really important. I think it's a really important thing to stress with your patients that once you've had that diabetic foot ulcer, once it's healed, you're really in remission. And what that means is that you need to be followed regularly, work on good A1C control, wear your proper shoe gear, and more importantly, be seen by a physician on a regular basis for high-risk foot checks. And then lastly, those screening clinics. And, screening clinics are important because just because those patients don't have an active wound, if they're diabetics and they have neuropathy, they're already at risk. And so, one thing that we can do really to even not have to get into the rest of these kinds of clinics here is, basic screening clinics. So somebody gets seen by their PCP. There's a great tool called the 3-minute foot exam, which kind of helps guide them into how to stratify these patients. They get seen in a screening clinic, and then they get put in the proper follow-up care, meaning number one, they are screened for any pressure points and put into high-risk foot gear. If there's an option for remote patient monitoring, that's an option for these patients. And really the idea is to get to them before they develop a diabetic foot ulcer. And so how does an APP run toe and flow center look like? And so, typically you have sort of an outpatient run clinic that can be done by MDs, DPMs, APPs. I think in more and more settings now, advanced practice providers are now running clinics and doing a fantastic job at doing the ground level work and then escalating when necessary to triage for any greater surgical need. Creates fluid, easy, and fast communication, frees up, the surgeons to be in the hospital, do rounds, be in the OR, treating those patients as they should be in those clinical settings, but also being there for their APP team. And then, the toe and flow inpatient availability at 24/7. So allows, again, us to be a bit more free outside of the clinic setting to be able to take better care of our patients. And then really just two other slides to cover. I think there's, really two arms and how things work for inpatient and outpatient toe flow. For the outpatient toe flow in a quintessential podiatry vascular toe and flow center, you have side-by-side clinics. What this does is help to sort of mitigate the patient from having to come back or getting lost to follow-up. One of the things that I enjoy about working in a multidisciplinary center is that, if I have a quick question, I call over to my colleague who's right next door, and he pops over, somebody from his care team comes over, and really we're getting ultrasounds immediately and care plans put into place immediately. We know that sometimes these patients have to get referred out to other physicians. That may take 2 weeks. And then, then they don't get seen, and then the message doesn't get back to the referring provider. And so that's where there becomes a discrepancy in care. And unfortunately, that's where patients get lost in the mix and wind up in hospitals and losing things they don't want to lose. So the clinics, really shared clinics, are critical. From the podiatry side, assessing for any need for orthotics and prosthetics in those high-risk patients, good wound care offloading, having access to radiology is also really great in the office. That way you can certainly assess for osteomyelitis. If you're surveying for osteomyelitis, chronic refractory osteomyelitis, you can do those things in the office versus having to send them out again for additional imaging studies. We know these patients outside of our clinic visits are going to multiple clinics and have multiple other doctor visits. And so if we can take what used to be 5 visits, and that would include visit with podiatry, visit with vascular, ultrasound screening, visit with wound care, and then follow-up care. That's almost 5 visits that these patients have to go. If you can combine that into one house under one sort of institutional setting, then we can all see the difference that it makes for our patients. So I think that's really important. And then having an office-based lab, again, just kind of demystifies all that goes on in the hospital settings. I certainly have my thoughts on what happens in the hospital, and I think if we can do more outpatient care, that's certainly better. Keeping these patients out of the hospital and out of harm's way is certainly great. Unfortunately, in this population of patients, it's inevitable that they'll wind up in the hospital at some point. Hopefully, that's a short stay. And then on the inpatient tone flow side, when you're running sort of that quintessential podiatry and vascular team, having regular OR time, block time is certainly nice. I know it's challenging in a lot of settings to do that, but I think if you're a high volume surgeon, certainly there's no reason why you shouldn't be asking the question of why you can't get dedicated protected time for you and your patients. Again, it's all about taking care of the patients. If you have cases that are typically going at 8, 10, 11 o'clock at night that are non-emergent routine cases, it's unfair to the patient, and it's unfair to the team to be able to do that. And so, I think that it's really important that if you're seeing high volume and you're doing a lot of work at a hospital setting, that you need to talk to your administrators about getting dedicated time. And the vascular side, doing non-invasive diagnostics in-house is important. Podiatry, wound care coordination. So once you've done your work in the inpatient setting, is trying to coordinate them to make sure that they have proper care in the outpatient setting, either via home health, are they going to inpatient rehab facilities, are they going to skilled nursing facility? You want to make sure that coordination of care is seamless and the Passover. I'm sure we've all been there with challenges and things that we go through trying to help our patients as they navigate through the system. And, I'm certainly not here to tell you that my system runs picture perfect. We have a fair share of our own issues, more so from the external components than the actual internal components. But we have to take all that in consideration because ultimately the patients suffer throughout this process and they don't know. And so educating them and being their advocate is critical. And then also that block time for the vascular team is really important so they can get their cases done and make sure patients don't sit in the hospital longer than they need to. And then really kind of having, rounds on a regular basis with the whole team, I think is critical. Rounding with your APPs, your trainees, your toe and flow team. I think that's really critical because you can spot on, have a plan of care, and make sure that things don't get lost in the mix. One of the things that we do in our clinic is we do clinical rounds every Friday. So every Friday at 7 a.m. before our clinic starts, we go through all of our higher risk patients. That would be our PAT class 4s, and we talk about them. Sometimes it's 25 patients. And so, we have a great system to kind of work that out. And it really does help because things get caught. We're all busy. We're seeing hundreds of patients a week, and we're all get busy, and it's hard to think of Miss Smith that we talked about on Monday and what the plan was for Friday. So being accountable for your own system is really important to make sure that these patients don't fall through the cracks. But more importantly, it's the best that we can do, and we have the duty and obligation to do that for the best care of our patients. So with that, I will pass on the baton to back to Kara Couch, I believe.
Yep.
If she could pick up advanced therapies to heal complex wounds. Thank you, Kara.
Thank you so much. Amazing. Okay, so how do we do it? What are our various treatment options for advanced care for these patients? This is not all inclusive. I would also say that doing something like a multi-layer compression bandaging or total contact casting is not advanced treatment. It's standard of care that we have. So when you think about more advanced treatment options, we have cellular and tissue products, hyperbaric oxygen therapy, and negative pressure wound therapy, and all of which could overlap, as I mentioned before. So what's in a name? You will hear various names when it comes to CTPs, which is cellular tissue-based products. That's what Medicare or CMS will refer to it as. You also may have heard the term CAMPs, which are cellular acellular or matrix-like products, because that kind of all encompasses the various options that we have now that we have even synthetics that are out on the market that we use. And the kind of old school term is skin sub. So you will hear that. But that when you talk about these things, what you're basically referring to is some sort of cellular or acellular or decellularized matrix or a synthetic matrix, or even you could use something like a borate-based glass that you could use for some of these patients. So how do you choose what it is that you are, how we're going to pick on this? So it's as clear as mud. You can see that there are lots of different things to consider. What does the insurer pay for? What does the manufacturer pay for? What does the patient want to think about? What does your institution have on their formulary? Is it shelf life stable? What does the surgeon or the proceduralist want to use? So I think that with all of this, the key thing we want to think about is making sure that things are safe, and that sorry, those things just didn't pop up for some reason. Basically, safe and effective are the key things that we want to look at here. Now, when it comes to the modern medical team, there's lots of different people in the procedure room or in the operating room with us. So you could have, the case manager, utilization review, the billing, insurance, discharge planners, the doctors, the nurses, and, who is, the decider of that. And it's usually not, unfortunately, the doctor or the nurse. So we don't always get what we want. When it comes to hyperbaric oxygen therapy as part of the treatment approach, this is a really powerful adjunctive therapy. Can be used for about 10 to 15% of patients with chronic wounds. I actually was explaining it in an email today to a patient's family member, the high benefit and, where for non-emergent indications, it is, we have known evidence that it is very effective for traumatic peripheral ischemia, chronic refractory osteomyelitis, diabetic wounds of the lower extremity, compromised grafts and flaps. We do that frequently in our facility. And then also works very well for treatment of damage caused by radiation therapy. So when it comes for wound hypoxia, we need to get oxygen, we need to get blood flow back into these wounds, or we won't be able to heal them at all. So what are you doing with having, these patients that have this reduction in oxygen delivery? So they are having issues with peripheral vascular disease or peripheral arterial disease. They could have edema, damage to their blood vessels. They have microvascular circulatory problems, i.e. from diabetic angiopathy. So the coincident conditions such as infection, pain, anxiety, or hypothermia, they could have a compromised pulmonary system. So if you are not, your lungs aren't working well, if you have sleep apnea, that is going to have hypoxia to your wound. That's why it's really important to consider getting sleep studies on our patients to check for obstructive sleep apnea, because a lot of wound care patients actually need to have a CPAP machine at home. When it comes to the wound itself, there's a lot of damage to the microvascular or capillary system just from trauma, even from doing debridement. You're crushing these fragile cells that sometimes you need to have more protected. So how we train people, as Dr. Lepow was mentioning, the trainees, it's so important. They have to have the right surgical technique and skill so they're not crushing the fragile tissues that we're trying to protect, so we can get them to a healing state. Obviously, edema, necrotic tissue, and then infection or biofilm we have to look at. And then from a cellular activity standpoint, from the immune response, we're producing these reactive oxygen species. The host cells need this. We need to have oxygen in to help get energy to function, and then to treat the bacteria and the fungal proliferation, because it's consuming a lot of energy. So this is what we have to look after to treat for hypoxia, which is why oxygen as an adjunctive therapy is a complex advanced therapy that we should always consider if possible for these wounds. Now, when it comes to negative pressure wound therapy, it starts with the wound healing basis. So we have talked about this all the time, and a lot of terminology comes around. If you might hear the term vacuum assisted closure, but really what it is negative pressure wound therapy. And when I'm ever teaching my students or my trainees, my residents, I say, how does that work? And they go, I don't know, it just works. Well, no, there's a method to the madness. There's a reason why we do these things. So traditionally, negative pressure wound therapy works by macro strain where it's drawing the wound edges together and pulling out the infectious material, reducing edema and promoting perfusion. That's why the 125 is the magic number, because in the studies, that's what shows the optimal perfusion. But then you also have micro strain, which is showing that when the foam is in contact with the cells, you're getting a micro deformation of the tissue, which is leading to a cellular stretch, which leads to proliferation. So that's how we get the rapid improvement that we see with these patients. You get macro strain and micro strain. And then when you add in an additional therapy of installation and dwell phasing, that is actually going in. There's an indication for hydromechanical debridement. So say you have a patient that you can't get to the operating room quickly because they're unstable, or there may be some issue like, that you couldn't get your block time, or whatever, your case gets bumped. You can actually start them on a installation and dwell therapy, which will liquefy and solubilize the wounds and really get some debris starting to loosen out of there. Now, again, if this wound hasn't been debrided at all and you have like a big, thick yellow slough or a hard eschar, that's not what this is for. But if you have an open wound that you need to start moving the process on, this is a good option to keep these patients moving forward. And there's a lot of evidence to support the use of that. And when you think about wound management with negative pressure, there are lots of different options. You have, as I just mentioned, the installation and dwell, which has been shown to reduce the time to OR, reduce the time to closure. You have the portables, which we use frequently in clinic, which can be mechanically powered and non-mechanically powered. We have incisional negative pressure therapy, which is helping to promote the healing once the patient has gone on to definitive closure. And then now we have extended wear negative pressure, which allows the patients to wear it for up to 7 days, in addition to the traditional, in a wound care and for lower extremity wounds, you don't see the open abdomen as much, but that is another option that you can use to help with complex wound management. Now, when it comes to skin substitutes or CTPs, this was a brief that was released back in 2020 by AHRQ that went over all the different items that were out there. And, I will say that there are many more commercially available products that are out there, and a vast majority are categorized as acellular dermal substitutes. And then within this, we have some cellular dermal substitutes, epidermal, and then dermal substitutes. And again, as I said, now we also have synthetics and things like that. So one of the challenges, if you have been anywhere in the US in the past 2 years, there's been a lot of issues around coverage and the ballooning use of CTP products, which actually accounts in 2024 for 15% of all Medicare Part B. So the challenge is that the vast majority of these products out on the market have very limited evidence, and so that's an issue, and that's something that we have to look at. But there are products that are out there that do have systematic reviews, they have RCTs, they have real world data and things like that we need for our patients. But it's been kind of a challenge to weed through the morass. But there are some changes that are coming in 2026 that will help to have us take a step back and look at it from a level playing field, and make sure that we are getting patients products that have both evidence and data and coverage, and that they are actually going to help our patients and get a good optimal outcome for those patients. So again, from these camps, not all of them are of the summer variety, as we should say. There's a statistically significant reduction from an economic review that was done in 2023 that looked at using for diabetic foot ulcers a bilayered living cellular construct, a dermal skin substitute, or cryopreserved, and then for venous leg ulcers, again, the bilayered or the cryopreserved, compared to all the other cellular or tissue-based products. And with that, they were able to get improvements with fewer applications, lower cost, and comparable or reduced incidence of amputation. Those are secondary endpoints, but of course, that's a great outcome that we want for our patients. We don't want them to have more amputation, which is why we're moving to these advanced therapies for these patients. So with that, I'm going to turn it over to Dr. Bruno.
Thank you very much. Good evening or good afternoon, everybody. I'm Rich Bruno. I'm a CPM in the Hampton Roads, Virginia area. I want to thank ALPS for having me to let me contribute to this. It's a great privilege to be on this panel with the physicians that we have this evening. Appreciate you all being here. We're going to get into some real world cases and evidence and applications. We all deal with these wounds in our practices every day. And we're all educated. We're all, very good at what we do, and kudos to you all and your dedication to patient care. I want to focus on a specific graft, a fish skin xenograft. There are a lot of products out there. You have your bilayers, your amniotics, so on and so forth, and they're all great. They're all tools in our toolbox. And so I just want to kind of highlight some information on the fish skin xenograft, share some of my cases and experiences with my multidisciplinary teams and my outcomes. So first, just kind of getting into the fish skin usages. The only real contraindication is in a whitefish allergy. You can use it with shellfish. You could use it with diabetic wounds, trauma, burns, inpatient, outpatient, private office, a lot of opportunities to get your hands on this to help with your wound healing. One thing I will say is while you can use it on draining wounds, just like most grafts, we notice that there are some increased signs of drainage when we do these graft applications. So it's something where you may want to see these patients back in your clinic a little bit more often, or just make sure that you get that under control. This is just some information how the fish skin is homologous to human skin. There's no known viral risk. It's gently processed, very easy to handle. Just again, a very nice product to use. We know our hallmarks of tissue healing. You want to maintain your natural mechanical properties, increase your molecular organization, drawing your fibroblasts to the wound. This is all something that you get with most of your grafting products. Here we can see under some electron microscopy, I was a chemistry major and science in college, so I always nerd out to these types of slides where you can kind of see the structure of the fish skin graft as well as the human skin. And, you can see like goes with like and how similar they are. And that's something that is beneficial when it comes to wound healing. This just kind of goes into the three-dimensional structure, talking about keratinocytes, fibroblasts, kind of, penetrating or moving into that wound with the assistance of the fish skin xenograft. Very easy to handle, very strong mechanical properties. I know nothing more frustrating than being in the OR and handling a product where you're feeling it kind of be frayable or tearing through suture. That's something with the fish skin xenograft that I've noticed that it's very easy to handle. Robust, but not too robust, kind of like Goldilocks and the Three Bears, not too hard, not too soft, just right. So you can rest your head on that pillow. Something that you can very easily use, very adaptable in the OR. It's something where you can use staples, sutures, steri strips. That's another nice quality of it. Talking about the molecular content, again, you can see your collagen, your elastin, your fibronectin. These are things that are all great, foundational key components to wound healing. And so that's something that this fish skin graft does have. So going into research, there's a lot of studies, just like most, graft products out there. There's a lot of good research that goes into this. This is something I won't dwell on too much, but this is always available, so feel free to reach out. This is a trial and a study specifically that I do want to highlight, the Odin trial that talked about intact fish skin graft to assist with healing of wounds with deep structure exposure. So your Wagner 3s, your bone exposure, your tendon exposure. This is something that I've had a lot of experience with over the years and that I do want to highlight because, with other products, I've noticed that some of these, whether it's a bilayer going right over top of bone, I don't have that success rate. But with the fish skin xenograft, I've noticed I really can open up my arsenal when it comes to these deeper wounds with the bone exposure, with the tendon exposure. And you could see here the comparative studies of healing where standard of care, which was, just your dry sterile dressing versus the fish skin xenografting, 16 weeks of healing rates, comparative 44% for the fish skin versus 26%. And then continuing that up to 24 weeks where it's 55% and then 37.8% respectively. So just really getting into our bread and butter here. These are the cases. This is where, I love what I do. And you're going to probably hear a change in my voice because I'm passionate about the cases and the patients. And we got some interesting stories to tag along with it. All these patients, all these cases is something that demonstrate that multidisciplinary approach. Whenever we have a diabetic come in, we're talking with our nutritionist. We're making sure they have their PCP appointments, their endocrinology referrals, making sure that if there's non-palpable pulses, we're getting our vascular studies, calling our vascular colleagues. If it's something that's really quite beastly of a wound, we're going to call in our plastic surgery team or anything that we can get all hands on deck to really optimize our patients. There's one case specifically where I'll kind of highlight that, but this first case, you have a 43-year-old type 2 diabetic, neuropathic, came in with a right hallux wound. This gentleman fell asleep on his recliner with his dog licking his toe. He had an infected ingrown nail. And when he woke up to his dog had eaten half of his toe. There was an exposed proximal phalanx bone. It was seen in the ED because he was in a pool of blood around his foot. He panicked. The ED saw him, put him on PO antibiotics, and sent him out. He called my office and presented that following week, and I immediately referred him back to the ED for admission and surgical debridement and intervention. I had that talk with this patient. Obviously, we're looking at exposed bone, recommending hallux amputation, high chance of infection here. And this gentleman wanted to try to fight to save his toe. So on his initial presentation, this is what you can see. You can see that bone from the phalanx exposed. Overall, maybe a little bit of erythema locally there. He presented May 27th, took him to the OR, and then we did a debridement with an application of the fish skin xenograft. And first post-op visit, you could see the micro portion of the fish skin xenograft that is still in that wound. You have a nice, healthy, red, beefy wound. This is a gentleman that, despite his neuropathy, the diabetes, he was vascularly intact. He surprisingly was one of the more controlled diabetic patients that we'll see. And so at this follow-up, we just applied an adaptic DSD, saw him weekly, and then on 6/19 transitioned to the betadine. So leading up to that next appointment, after that 6/19, it was 6 weeks into treatment. He had an in-office application of the fish skin xenograft, which you can see there. The wound is contracting. There's no longer that bone exposure. We did take the phalanx sample that showed acute osteo, and fortunately, we did also get a clean margin with that, which was very fortunate. And so we did that application and then continued to see this patient weekly. And then as he presented on 8/7, he was healed with a portion of his proximal phalanx preserved, his hallux preserved, with the assistance of the fish skin xenograft, which is a tremendous outcome for a gentleman like this. He came in healed this day. He's in construction. He keeps popping one day his appointment, he stepped on a nail, another day some type of glass. So I got him healed on this appointment, and then he keeps coming in with these little nicks and crannies, and I'm begging him. I'm like, please, can you please just come in once and be completely healed again? But he's overall doing okay. This next case, 53-year-old type 2 diabetic, hemoglobin A1C of 13.6, so really uncontrolled. Came in with a left lateral fifth MPJ wound with an abscess and osteomyelitis to the fifth ray. For this case, for our multidisciplinary approach, we were instantly on the phone with infectious disease after we did that initial partial ray amputation. Got him on the proper IV antibiotics and maintained that course. He unfortunately did have the infection tracking to the fourth ray, so we did a partial fourth and fifth ray amputation. Again, the osteomyelitis was confirmed on pathology. So we opened him up, coupled this with a negative pressure wound therapy, and did the fish skin xenograft. So we could see here with that initial application, you could see tendon exposure, bone exposure. I do one thing, my residents always make fun of me. I always highlight this. I do a stacking technique with the grafts that I am able to use, because whether it's a financial reason for the patient or it's something where the graft can really just kind of feed on top of it. Trying to optimize him better. Did have our vascular team try to get him in a better position to heal. With this case, we had a long talk about, hey, salvage, what do we want to do here? And with his contralateral BKA, we stressed that salvage approach. And we said we were going to try and do everything we could to salvage the big toe, keep him ambulatory, not make him wheelchair bound if we could help it. And so we did that partial third to fifth ray amputation, did serial debridements in the setting, of gas gangrene. And we see here, this is what the wound was looking like. We did negative pressure wound therapy, wasn't too responsive around the second metatarsal phalangeal joint. That capsule was exposed. So unfortunately, we did have to modify. You can see here more of that fibrotic growth with the negative pressure wound therapy. So at this point, we said, let's take the second, partial second ray as well, use the fish skin xenograft and see what we can get out of this. So 1118 to 1229, you can see more of that granulation tissue backfilling that contracture of the wound around where the second digit was. So felt like we had something going here when we started using this. Did another application. You could see once again that wound getting more narrow, going month to month with those dressing changes in between. And then we did an additional application, and by end of March he was fully healed. This is a gentleman who now, over 2 years later, I still see every 3 months. He is walking with his prosthetic on the left side. He will come into my office. I will trim up that big toenail for him, and he's as happy as can be. And it's something where obviously we're looking at a foot where that looks like that foot's giving you a thumbs up, but I always say we're looking at a foot though, and that's what's important. We have this gentleman walking. So while I can be a little bit of a cavalier or cowboy when it comes to limb salvage, this is a gentleman who's a testament to this approach, and very happy for him and our approach with this. I do have one final case. This is another tough case where 52-year-old type 2 diabetic female came in with a hemoglobin A1C of 14.2, another gas gangrene infection. For this patient, once again, that long, honest conversation about, hey, do we want to pursue proximal amputation? Do we want to pursue salvage? Understanding, multiple surgeries, the road that we're about to embark on. It's not going to be like you wake up tomorrow and you're okay. And after that very frank discussion, she said, let's try our best. She required 3 surgeries. The initial open TMA, where we tried to preserve our plantar flap. Unfortunately, that necrosed. Unfortunately, there was infection still tracking medially along where the hallux and the first ray were. So we had to go back 2 more times and pretty much converted her to a guillotine TMA. So what you're seeing here is before her initial application of the fish skin xenograft, where we did an aggressive debridement, did the graft, coupled it with the negative pressure wound therapy. You can see here about a month later how we have that granulation tissue backfilling. What you can't appreciate is medially there is still tracking there. So we went ahead and we debrided and we backfilled that medial tracking area. Continued the negative pressure wound therapy, and then in that photo about a month later on 4/13, patient granulated in, backfilled in, so you no longer had that tracking. So we went ahead and did another in-office application, and at this time we discontinued the negative pressure wound therapy since everything was quite superficial. And you can see here, over the course of 4 months with 3 applications, we were able to get the patient healed. From left side to what you see, I still also see her in the office every few months, got her diabetic shoe with a custom depth insole, and she's doing very well. So those were just some of the cases I wanted to share. I know we want to leave some time for questions and answers. So I want to thank you all for your time and for being here in this opportunity.
Excellent job. Really, again, when we're talking about the team, I mean, we have the team right here outside of our IT people and Kara Couch and Richard Bruno. Y'all did a fantastic job. Kara Couch did a great job talking about advanced therapies and management of wounds, as well as sort of wound assessments. And Dr. Bruno kind of ending the session talking about how fish skin grafts are used for diabetic limb preservation and use for chronic wounds. So great job to the team. Sorry to everyone out there that we lost you briefly, but this is recorded and everybody can kind of pick up where we left off. And I appreciate everybody's time for today. We'll cover some questions. We have some questions come through the chat. I'll toss them up to the team and we'll get to it. So we had one question that came in, and the question was, given the high incidence of diabetes, distress, and mental health concerns in this group of patients, who and when on the multidisciplinary team should be doing the assessment? Who is the best resource for managing, and who follows those issues? I could take it or toss it out there. We can each, I can suspect we each have different answers to the question, and I'll start it off really quickly. I think it's a great question, but the reality is I think it kind of depends on the setting that you're at. I think the key thing to highlight in this is mental health concerns. We talk about that all the time in our clinics, and in fact, what we're going to have start doing is we're going to start a mental health clinic within our own clinic. And so, we realize the need for that, and we will have somebody that'll join our clinic. And we also have wonderful APPs that have worked in primary care settings that help to kind of work towards a more well-rounded approach with these patients. But certainly so, I mean, look, in every setting is different. I think if you don't have active members of that team, you pair up with diabetologists, endocrinologists that understand and want to work towards limb preservation and can kind of help you. Kara or Richard, do you have anything to add to that?
Yeah, I mean, I think that the key thing, like you said, is you have to work with what you have, and there's ways that you can train up different members of your teams to do very simple screenings of these patients, and then work with different ways to hopefully more positively impact the patients and understand, like let them know that we are here, we want to help and try and gather some local resources. I mean, I think the dream would be to have a psychiatrist available on all of our teams, as well as a nutritionist and a social worker or a navigator. Like that would be amazing. And throw in a lymphedema therapist, you got the whole shebang there, with everyone else you listed. But I think that, not ignoring, but not thinking about this is as serious, if not more serious, than not thinking about nutrition. Because a lot of our patients have chronic depression, they have a lot of anxiety, they don't have a lot of health literacy in general, and they don't really understand like the long course that they're going to be with us. So I think that developing some simple techniques first is something that people can adapt in almost any setting.
Yeah, I agree with everything you guys are saying. And one thing is just, continuing to branch out with our multidisciplinary specialists, whether it is mental health, primary care. I know locally here in Hampton Roads, our primary care doctors get together quarterly and they'll have their kind of provider meetings. And twice a year, I'll discuss with them if it's possible to come into their meeting and, talk for 10 to 15 minutes, whether it's about a difficult common patient or different common pathologies that we're going to be managing together, and trying to branch that out to other specialties and kind of that grand round setting, making sure everybody's on the same page moving forward with patient care.
Yeah.
Great answers. And as I suspected, depending on your setting, it is going to vary. But all things that we should kind of take in consideration when management of this population of patients. I'll move on to the next question. When trying to prevent amputation regarding severe Charcot-deformed foot, how does one find a local, hopefully a doctor, who is both experienced and confident in treating these severe deformities? This is a very targeted question, and I think it really kind of depends who has the skill set and knowledge in your community. And I think it's a matter of sort of doing some research to find that out. There's great foot and ankle podiatrists, great orthopedists out there that do good work for Charcot recon. The American Limb Preservation Society does provide a resource to connect you with various individuals who have certain skill sets and specialties. So I think that's a great resource. You can certainly email the American Limb Preservation Society looking for your person of interest, and we can certainly look to connect you there. Kara or Richard, I don't know if you have anything to add to that.
I can go second if that's okay, since we switch off. Communication. Obviously, don't be shy in your community. Reach out to local providers, see what they're comfortable with. Everybody's got their resume online nowadays. You could see where they trained. And don't be shy to cold call people and reach out. And, it's not like we need to be pariahs with each other in our fields. We can reach out and say, okay, hey, I have this case. Are you comfortable with it? When you go to conferences, reaching out to these committees, these societies where you can get connected. If you go to a conference and you're at a Charcot lecture, look around the crowd, see, don't be shy to ask questions to the panel, talk to your neighbors or people, just, that's where we're supposed to network and learn these things. And obviously you may not get somebody local at that, but maybe you could get that word of mouth. So just really don't be shy with communication and doing your research.
Yeah, and I think just the final point I'd make to that is just, you should be able to ask providers, how often do you do these cases? If they say I do one, Charcot case a year, that may not be the experience level that you want. But if they say, oh, I do, a couple a month or things like that, like, the more we do things, the more that you can have some, like just like kind of baseline experience and comfort with treating complex conditions like Charcot.
Awesome answers, everybody. We have a few more minutes. I want to be cognizant of our time, but we can get into one or two more questions. And I do apologize if you're sending a question we don't get to it today. We can try to answer those in a form outside of here. Next question. When do you decide to try the CPT treatment like fish skin versus conventional treatment, i.e. a number of weeks of failure of a wound closure to satisfactory degree? Richard, I'll put that out to you since you were covering the CTP portion, and certainly Kara as well.
Sounds good. Yeah. You got to let the wound speak to you. You know, we're experienced. We see what we're dealing with. Is that wound down to bone? Obviously, I'm not going to use a certain product or something there based on that. Is there infection? Got to get that cleaned up. I'll usually treat wounds probably for a few weeks to a month, and then I get really aggressive. I try to push that boundary when I can. Obviously, we have our standards in the office and guidelines to get things approved, but if I can get more aggressive, I will. But ultimately, it's just figuring out what type of procedure is this patient going to need, and then what that wound is going to communicate to me it needs if it seems stalled.
Anything to add, Kara?
Yeah, I mean, I would agree with that. I think that the main thing is, the longer we wait, if the wound is not improving or has stalled out, it's not going to heal with conventional therapy. We need to be more aggressive. We need to move to advanced products. So, if you're not getting, traction on these wounds within a month, time to shift, time to pivot.
Yeah, I would agree. And I think the point to hit home there is really 4 weeks of conservative standard of care. If the wound hasn't failed to heal, you really should consider outside modalities and more advanced care modalities to help get these wounds to closure. And we got another minute left here. I will go ahead and chime in with another question. Hang on just a second. Really great stuff coming through here. We have a question about with the polyvascular issues and the main mortality in the diabetic PAD patients due to cardiovascular disease. I'll shorten this a little bit, but really the question is, would it make sense to have a cardiologist on that team? And I'm all for it. Yes. I mean, we work with cardiologists very closely. I wouldn't necessarily say they're in our offices, but we have regular referrals back and forth with cardiology. We have our team that we can lean on, and I can pick up a phone and call the cardiologist for any types of questions regarding that. And I do think they're a critical part of this team. Anyone
Yeah,
else?
I mean, for sure. There's lots of interventional cardiologists as well that are part of the toe and flow team on the flow side. But I think that, cardiology, understanding its critical role in wound care is something that we also should be going out and teaching them. Like, for example, when I gave a lymphedema talk a couple years ago to my cardiology group and was explaining how actually diuretics are contraindicated in lymphedema patients because you are making more of a protein clot mess in the lymphatics, and their brains, like, I just watch them like explode in front of me because they're not taught this stuff. Wound care is not taught. So it's on us to get out and teach the people that are treating the people.
Spot on with that lymphedema. Absolutely. These underlying contributing things that get in the way of wound healing. Also, just simple enough, like getting cardiac clearance to take them to the OR. God forbid you don't want something happening. So 100% they should be involved.
All right, everyone, we are rounding the hour here. It's now 7 o'clock, and just wanted to let everybody know that we really appreciate your time and attention. Great questions. Thank you, Kara Couch and Dr. Bruno, for your insights and your knowledge. Thank you to the American Limb Preservation Society for their work in putting this together. And most importantly, happy holidays to everybody. Please have a safe and happy end of your year, whatever that may be. And we look forward to seeing everybody hopefully in 2026. Thank y'all very much, and appreciate everybody's time.